opportunity to report about our experiences with the jet ventilation in the ENT field. I am an anesthesiologist and also a lecturer at the Technical University, but I am not a magician. So, weiter geht es weiter. The next. Here. Jet ventilation is no magic. It is based on different physical properties of the jet gas, which are not visible. However, the result of these effects are visible. Kann man da was wegmachen?
Ja, das passt.
Na, den Rand oben.
Musik.
Ich sehe es nicht. Aha. Here you can see the table of contents. First, I will report about the introduction to jet ventilation, then the physics behind the jet ventilation, then the combination of high and low frequency jet ventilation, the indications for all jet ventilation techniques, jet ventilation using catheter techniques, and then supraglottic jet ventilation without catheters. Then a lot of clinical examples, and then the conclusion. Here you can see the development of jet ventilation. Here are the authors who have been involved in the development of high-frequency jet ventilation. And in 1982, El Paz creates the term combined high-frequency jet ventilation. Please remember this term. You can see a variety of description of methods used. This variety is confusing, but I will make these techniques understandable. In astronomy, jet is a directed gas flow. In medicine, jet is a directed gas flow through a nozzle. The gas outlet from the nozzle causes a massive loss of pressure. The pressure in the nozzle is 2000 millibars, and 20 centimeters further down, only 20 millibars. 2 bars equals 2000 millibars. There is a 100-fold loss of pressure. Therefore, the nozzles are localized proximally and not distally in the endoscope. Special terms for the jet ventilation are the behavior of the gas flow, laminar or turbulent is a turbulent flow. The free jets you will see a little later. The Venturi effect is a suction of the jet gas in the area of the nozzles. The Venturi described this effect, but Bernoulli mathematically formulated it. The Joule-Thomson effect, an increase in volume of the gas after the nozzles lead to a cooling of the gas. And then the oscillations can superimpose each other. Here you can see the entrainment and the pressure in the jet laryngoscope. At the tip of the nozzle, the pressure decreases. We have a negative pressure, and then the pressure increases. Look on the left side. This is the Bernoulli equation. The Bernoulli equation, the sum of static pressure and dynamic pressure is constant. When the velocity on the left side increases, the pressure on the right side must decrease. And therefore, we have here a negative pressure. That's verständlich. Here you can see the characteristic of free jet. The free jet character of the jet gas creates an entrainment of room air in each zone of its jet stream. When the oxygen concentration on the top of the needle is 100%, 20 centimeters further down, the oxygen concentration is about 70%. And this is caused through this entrainment of room air. You can see a typical turbulent gas flow with a high Reynolds number. And here you can see the application of the jet gas. We use a nozzle. The diameter is 1.5 to 2 millimeters. The pressure 0.5 to 3 bars, and the gas volume 50 to 300 milliliters. We use a jet catheter, a jet needle, a jet laryngoscope, or a jet bronchoscope. Here you can see the differences between jet and conventional ventilation. On the left side is the conventional ventilation. We have an endotracheal tube. 8 millimeters is the diameter. The pressure is low, 20 millibars in the tube. the volume is high, 10 milliliter per kilogram body weight, and the frequency is low, 12 times per minute. On the right side, the jet ventilation, we use a catheter or a jet nozzle. The diameter is 1.5 to 2 millimeters. The pressure is high, 1,000 to 2,000 to 3,000 millibars in the catheter or in the nozzle. The volume is low, 1 to 3 milliliters per kilogram body weight due to high compression of the gas. The frequency is high, 1 to 25 Hertz is equals 60 to 1,500 times per minute. And here you can see the dependency between jet volume and jet frequency. When the jet frequency on the left side is high, the impulse tidal volume is low. When the frequency is low, the impulse tidal volume is high. You can see the same, the correlation between frequency and tidal volume. When the frequency is high on the right side, the tidal volume is low, 20 milliliters. When the frequency is low, the tidal volume is high, 70 milliliters per kilogram. And now the types of jet ventilation. We have the low frequency jet ventilation. The gas is applied at low frequency, 12 to 20 times per minute with a high pressure in a narrow nozzle. Then we have the high frequency jet ventilation. The gas is applied at a high frequency, 60 to 100 to 800 times per minute. This is a common technique for the surgery problem, reduced PCO2 elimination at high frequencies. And then you can combine low frequency with high frequency jet ventilation. And this is a combined high frequency jet ventilation. This is a simultaneous application of low frequency and high frequency jet ventilation by separate nozzles. Solves the PCO2 elimination problem. Elbaz used two ventilation frequencies simultaneously in his study, and he created the term combined high frequency jet ventilation. We also use combined high frequency jet ventilation. We now have one respirator which can generate two frequencies simultaneously. Elbaz used two ventilators. Here you can see the behavior of low and high frequency. Here is the low frequency jet ventilation with the high tidal volume and superimposed high frequency jet gas impulses. This is the inspiration. During the expiration, we have only the high frequency jet gas impulses. And then we have two pressure levels, a lower pressure level and a higher pressure level. This is inspiration, this is expiration. And here you can see our modified jet laryngoscope. On the left side is the connection for the low and high frequency jet ventilation. On the right side, the airway pressure and gas monitoring. Then in the middle of the handle is the connection for the humidification. Here you can see the setup for the modified jet laryngoscope, the humidification. This is the humidification chamber. This is the control unit. And then we have this tube system and the laryngoscope nose. You can see a clinical jet ventilation. On the left side, the two jets. On the right side, the gas monitoring. Then for the surgeon, optical fibers. And here in the middle, the humidification. Here a closer view of the jet endoscope. This is the low frequency jet ventilation. This is the high frequency jet ventilation. On the right side, the monitoring. And here's the humidification. Now you can see this ventilator can generate two frequencies simultaneously. The name is twin stream, and on the left side is the humidification. You can see a typical display. You can see the expiration with the high frequency jet gas impulses, then the inspiration with the superimposed high frequency jet gas impulses. And on the left side here, you can see the adjustment for the low or the frequency jet low frequency jet ventilation, the frequency is 12, the inspiration to expiration time 1:1, and the pressure 1.4 bar. And look here, the pressure is 16 millibars. The peak pressure, the mean pressure 12 millibars, and the PEEP, the positive end expiratory pressure 6.7 millibars. On the right side, we have the adjustment for the high frequency jet ventilation, frequency 600, inspiration to expiration 1:1, and the pressure 1.0 bar. And look here, the pressure in the endoscope is 16 millibars and not bars. And here in the middle, you can see the oxygen concentration when we use the laser surgery and the oxygen concentration is too high, the respirator can automatically reduce this high oxygen concentration to 40%. And here right is the limit for the pressure. You can adjust the high and the lower pressure when in this case the pressure is more than 34 millibar, the ventilation stops. And here you see the clinical situation in our operation room. On the right side is a ventilator, on the left side the patient, and behind the microscope the surgeon. And now indication for all jet ventilation techniques, optimization of surgical conditions. Then for the expected difficult airway, primarily for selected surgical procedures on the larynx, on the glottis, for laryngostenosis, for subglottic stenosis, for operation in the trachea, for stenosis and then the stenting. Stenting is an iatrogenic stenosis, and maybe tracheotomia. Wishes of the surgeon: a lot of space, no barotrauma, safe application of the laser, no risk of fire, no risk of explosion. These wishes can be fulfilled under the following conditions: no plastic material, no nitrous oxide, reduced oxygen concentration 40%. This is exactly what the jet ventilation provides. And here you can see the infraglottic jet ventilation without stenosis. This is the endoscope. This is a function of the membrana cricoidea with a needle, in this case with a rubber needle, or you can use a catheter and you can put this catheter through the glottis in the trachea. In this case, when the glottis is open, it is no problem to ventilate the catheter techniques. It is easy. And here you have a special catheter for the jet ventilation, the Hans-Ackermann jet catheter. This, on the top of this catheter is a basket, and this basket should reduce the movement of the jet gas impulses of the movement of the catheter. And here you can see this jet catheter behind the glottis, that this catheter is an hindrance in itself. Here you can see a function of the membrana cricoidea with a needle. When the glottis above the catheter is open, there is no problem to use this technique. This is very simple. We have in Vienna used all techniques. And here you can see the infraglottic jet ventilation with stenosis. The gas should be able so that no power to the stenosis to this stenosis. And here you can see this Hans-Ackermann jet catheter. This is the area to ventilate. It was possible to ventilate this patient. And ventilation settings for infraglottic jet ventilation with stenosis. You need a high frequency. The inspiration time should be short, the expiration time long, and the driving pressure low. See if the chest rises during inspiration, and which is most important, if it lowers during the expiration phase. If the chest doesn't lower, you must stop the ventilation immediately. And here you see possible complications of the catheter jet ventilation. General complications are barotrauma, subcutaneous emphysema, pneumomediastinum, puncture of the esophagus with overexpansion of the stomach and hematoma. There are two big studies from Bourgois. He investigated more than 600 patients and 8.4% ones. There were subcutaneous emphysema spreading to face, pneumomediastinum and pneumothorax. And Roussel investigated 90 patients with infraglottic catheter technique. He had 10.8 complication rate, and in one case a fire. Complication associated especially with our supraglottic jet ventilations, insufficient oxygenation and hypercapnia. And here you can see supraglottic jet ventilation without stenosis. This is the endoscope with the two nostrils. Then here is on the top is the pressure monitoring. And when the glottis is open, it is no problem. It is very easy to ventilate these patients. And here you can see our jet endoscope. On the left side here is a high frequency jet ventilation, and on the here's a low frequency jet ventilation. The jet nostrils are positioned in the back. The pressure at the top of the jet laryngoscope should not damage the trachea. And here supraglottic jet ventilation in case of stenosis, yes or no? Important question. Yes, the pressure behind the stenosis is always lower than the pressure before the stenosis, and therefore it is not possible to create an trauma. And here's the ventilation settings for supraglottic jet ventilation with stenosis: frequency high, inspiration time long, expiration time short, driving pressure high. The aim is to achieve a sufficient high pressure behind the stenosis. Here you can see the flow conditions in the jet laryngoscope during a stenosis. You can see here the stenosis. Here is a high velocity as the nostrils, and then the velocity decreases. This is the velocity distribution. And here you can see we have a simultaneous bidirectional gas flow. We have simultaneous flow in both directions, both during inspiration and during expiration. This to the left is inspiration, to the right is the expiration. And here you can see the vector field of the velocity in the region of the two nostrils, the typical shape of the expansion of the high frequency free jet left and the low frequency free jet right can be seen. You see this high velocity, inspiration, expiration. And here the pressure distribution in the laryngoscope in case of a stenosis. Here is the stenosis, and before the stenosis we have a back pressure, we have a high pressure before the stenosis. And look, behind the stenosis the pressure is low. It's the same comparison of the pressure before left and after the stenosis. The pressure after stenosis cannot be higher than before the stenosis, and therefore it is not possible to create a barotrauma. This is supraglottic jet ventilation. Here, children with superimposed high-frequency jet ventilation over a period of 12 years, number 198, age from 2 weeks, interventions, inspections, surgical interventions, laser surgical interventions, complications, major complications, none, minor complications, moderate hypercapnia. Here you can see the endoscopic removal of a foreign body from the trachea using the jet endoscope with the bronchoscope and forceps. You can see the removal of a nut from the trachea in a child. This operation is possible to perform in a short time. And here you can see the case report from China. This was a child with a congenital subglottic stenosis. And this is our jet laryngoscope, this is our monitor, and this is a typical display. And here you can see the anatomical situation. The subglottic lumen was so narrow that it was not even visible, but it was possible to ventilate this child. And here you can see a long-term intubation in an intensive care unit, the vocal cords, and behind the stenosis after remove of this endotracheal tube. But it is very easy to divide this granulation tissue with the laser surgery. You can see synechia between the vocal cord. You can cut this synechia with the laser surgery. And here is a typical laryngoedema. This was the area to ventilate the patient, and is easy with the supraglottic jet ventilation to ventilate this patient. And here you can see the indication for our jet technique. The use of a jet catheter is not possible. I cannot judge the chirurgical, anatomical situation, but I can ventilate the patient. This is important for me. And here a tumor-related occlusion of the glottis. This was an inspection, no operation. And here is the area to ventilate the patient. It was possible to ventilate this patient without complication. And here the stenting. The endoluminal stenting is possible with all stents. The anesthesiologist in the background looks at the surgical procedure with interest. He has both hands free. This is important. And here you can see in silico stent two guiding catheters for the main bronchi are placed. This would not be possible with a catheter. And here you see the expandable stent. I think you know all these stents. And a patient with jet ventilation at our department, we ventilated 1,515 patients, 158 children, 139 stenosis, and 312 laser surgeries. The youngest patient was 2 weeks old. The heaviest patient 120 kilograms. It is possible to ventilate this patient. And here you can see all the diagnosis of patients undergoing microlaryngeal and tracheal surgery under superimposed high-frequency jet ventilation. We could perform all operations without any complication. And here you can see the P as the oxygenation during this technique. It was possible to ventilate all these patients without complication. And the PCO2 levels during supraglottic jet ventilation, it was also possible to ventilate all these patients. And what are weaknesses of supraglottic jet ventilation until recently? Weaknesses is missing humidification, the entrainment of ambient air. Current improvements, warmed and humidified ventilation case. The entrainment as a physical effect cannot be completely eliminated, but due to a modification of the jet laryngoscope, its effect was moderate. Therefore, entrainment of ambient air was profoundly reduced, and now there is an entrainment of warm, humidified air with the same oxygen concentration as the respirator. And here, conclusion: superimposed high-frequency jet ventilation, optimal working condition for the surgeon, no constriction of the operating area, use of the laser. None of the known laser complication can occur. The high-frequency respirator has the same modern control mechanism as a normal respirator. There is no age limit for the ventilation. There is no time limit. Use for high-grade stenosis. One complication, contraindication, is the impossibility to adjust the endoscope. When it is not possible, you cannot operate. Then safe oxygenation and PCO2 elimination are important for the anesthesiologist. We use a total intravenous anesthesia with remifentanil and propofol. No anesthetic gases are used. And now I have a short video. This was a child with superimposed high-frequency jet ventilation. This is the beginning of the anesthesia with ventilation with the mask. So pre-oxygenation, and then the surgeon must introduce this jet laryngoscope. This is a jail. And then the connection for the ventilation. You can hear the ventilation. Here below, and see, and this is an optimal situation for the surgeon during the jet ventilation. I think this is okay. We could ventilate this child without any complication. Not just the chirurgical situation. The operation is over. And then I have an video by Professor Friedrich from the University of Graz, but we have no sound. You can see different operations. This is all laser surgeries. You can see the movement of the vocal cord. And look, if we have a bleeding, the blood is not sprayed, yes? We have an optimal site, this amyloidose of the trachea. Bei mir geht's aber. I think these are optimal conditions for the surgeon, and we can ventilate. This is important for the anesthesiologist. Is a posterior glottic stenosis after long-term intubation. The blick in the site in the trachea. And this surgery can be performed in a short time, yes. We have no catheter. And we have no smoke, this is important. We have no laser smoke. We have you can see this thread of mucus. This thread is not sprayed through the ventilation. And you can see the blood can.
And I'm not a doctor. I'm only an audiologist, but I'm a founder also of the company Hero Medical Incorporated, which has express goal to develop a new standardization for audiometry. You know, we still test hearing about the same way today as in the birth of audiology in the years after World War II. The time for a new audiometry has come, in my opinion. Today I am the smartest man in the room, as I'm home in my own living room, and I'm the only person here. So that's today's joke. You know, the technological progress of the rest of the world has far surpassed audiology. We still test hearing with a nearly 80 years old method, and the most common argument for keeping it this way is that we always have done it this way, and all the data we have collected is on this method. My claim is that it's not a problem to contain the data we already have collected, because if we make a software to collect audiograms anonymously from clinics and hospitals with the possibility of identifying the client when we contact the issuing party, we kind of makes it a lot easier regarding privacy rules. So this way we can create a database on all knowledge collected on audiology, you know, from audiograms. This can lead to us being able to predict better how hearing loss will progress for the different patients. And we can actually, once this is implemented, you can with a push on your button on your computer write out sorry, English is not my mother tongue, so sometimes I seem to be searching for the words. But you can print out expected progression of the hearing loss for any period you like, you know, 5 year, 2 year, and this is very important information for the clients. The clients want to know this. They are scared. They often don't know how this hearing loss will affect their lives. So to be able to do that with the data from people with the same diagnosis will be very good for the clients, and we are doing this for the clients, you know. So it's we really need to see them, you know. Pure tone audiometry is I can start with this quote. I love this quote. The electric light did not come from the continuous improvement of candles. This is by Otorhinolaryngology, a late professor from the University of San Francisco. He was professor of entrepreneurship business, and I think this quote tells us where we're at in audiology right now. An audiometry should point us in the right direction regarding clients, no matter what's wrong with them, you know. And today it doesn't do that really. People with various processing disorders, whether it be auditory processing disorder or binaural processing disorders, we don't really find these clients with pure tone audiometry, and that's why I say we have to make a new audiometry. And what better way to do it than today, when we get all these new technologies, like being able to create virtual rooms where you can perform extended testing on multiple scenarios. You can move walls, you can try furniture. You know, I want the new audiometry to be free field audiometry. That's the natural way we hear. I want to get rid of the headphones, as they totally disregard outer ear effects, and I think free field is the natural way we hear, and therefore it should be the basis for a new audiometry. Today, free field audiology is emerging worldwide. In Norway, for example, about 14% of audiometries are performed through free field pure tone audiometry. I want to take it a bit further and develop a totally new audiometry. This is not new knowledge. This quote is from 1993, and the scientific literature is full of similar examples. You know, we have known this for years. This program can show normal auditory thresholds with only 10% of the auditory fibers intact. And noise in the clinic. We have to bring the noise to the clinic. And you know, every hearing impaired person knows that it's when the noise comes into play that the real problems occur. You know, I guess if anybody here is working on audiology, I guess you have clients every day that not every day, maybe at least once a week, I think, that comes in and have a feeling that their hearing has deteriorated. We test them with pure tone audiometry. Very seldomly we bring in speech and noise, which we should have done, and we find the results to be pretty much the same, and we say to the client, no, your hearing is the same, but we can't really answer that. we can't really answer that unless we test speech intelligibility score in noise. And this is very important, I think. There are tons of research in audiology that never have reached clinical audiology, you know. So we need to rethink audiology as a field and develop a new audiometry, a new standardized way of testing hearing. And I strongly believe that this should be based on free field audiometry. Let's see. This is a picture of the R-space system. I love this system because it's a two-part system where you have one part to record various noise settings, whether it be a restaurant, real world noise settings, and you got this system to play it back to the client. My Otorhinolary product is kind of a smaller version of this. It's a speaker hat where you get speakers approximately 40 centimeters from the client's own head, from the center of the client's own head, which is the only constant in a free field test setting. So this way challenges the fact, or the established fact, that the optimal listening distance should be 1 meter. This is based on the wavelength of a 250 hertz sinus tone. But I'm confident that we clinically can produce comparable results with a shorter listening distance. Whether or not hearing size, no, the head size will impact the measurements or not, remains to be tested. And you know, there's a lot of possibilities. I think if we should develop a new audiometry, we need to bring in people from various fields, also neuroscience and other fields. You know, I kind of have this vision in my head where you try Beckesy audiometry. Georg von Beckesy, the Hungarian only Nobel Prize winner of audiology. He won the Nobel Prize for his research on hair cells, but he also developed a very good audiometry. And I want to try this in a free field setting, as it, you know, you can improve Beckesy audiometry up to the technological standards of today, you know, and then test in a free field setting, and you can record, let's say, 2 responses from the client, 1 ABR response and one client response. On Beck's audiometry, you push and release the button, and the difference between is called difference Lehman, and I believe this can tell us something more. But it's not what we know that is the most important here. It's what we can learn. It's what it's how this can bring audiology forward. This is how this can give us more information on the development of hearing loss. You know, it's the possibilities are endless. And to do this, you have to start small, you know. And the first product of Hero Medical will be a speech in noise test equipment. This will let audiologists test speech reception threshold in noise with hearing aids and without hearing aids as an evaluation tool, you know. This will give a clear indication on the audiologist feel of the situation. And you know, today we only got the REM system, real measurement system, as an evaluation tool, and this is in place in approximately 30% of clinics worldwide. So, so it's. Am I going over time? Please let me know if I talk too much.
No, not an issue, Doc. No, not an issue, Martin. You can present here.
Okay, thank you.
Yeah.
So, by testing the speech in noise, and then I talk about the speech in noise test, the scene test, Hagerman, or the hint test. You can use for this, and this gives a very good indication on how the client can hear in noise, and that's what matters. You know, how can they hear in noisy conditions? That is really the measurement of how well does this client function in society, you know. So we need to measure this, and these tests measure signal noise ratio, and that is of no importance as it's the decibel difference that is the effect of the hearing aids. Ideally, we should have a comparable value. For example, in percentage, and someone better than me in mathematics should be able to calculate. You know, decibel scale is logarithmic. So if we use the decibel measurement, it's not comparable from one client to another. You know, how well does the hearing aid work for this client, and so on. But by doing this, sometimes you can develop normative material on how much a hearing aid is expected to help a client in with this and that hearing loss, you know, and this is very important because that way we will learn what hearing aids are working best for the client and put a huge pressure on the hearing aid producers to make better hearing aids. The fact that this isn't in place today, I find very strange. You know, even today the way we test directional hearing, it's so Stone Age. We go behind the client, make noise, and observe which way they are turning their head. With my system, with more speakers, you can get kind of very, very good directional hearing testing, and you can actually this can result in therapies for directional hearing. We can learn a lot more about directional hearing. We can see if can we train this to be better? You know, today the hearing aid producers are telling us that for example, with the cross hearing aids, that they can develop a sense of directional hearing with the delay from the cross. You know, it would be really interesting to test this and to see if we actually can do this. And if we can, how can we better help the clients to use this and to better develop their directional hearing sense. This system will also give us the possibilities of this system, you know, is immense. Also, tinnitus, I think this can result in new therapies, but we have to get it into the clinics and start testing. I believe, you know, back in 2007, 2006, 2007, Biologic came with their Hint Pro. I don't know if you remember, but and then it was free field testing was the new way forward for audiology. By unknown reasons, they shelved the system. I believe them then, and I believe them still today, that free field is the way forward for audiology. There really is no way around it if audiology is to prosper. If we are going to learn new things about hearing, this is the way. So yeah, no, I'm a little. I have a quote by myself. It's not published anywhere, so I don't really have the right to use it as a quote. I do it anyway. No field is stronger than its source of information, and we really need to collect the right data, the data that can give us knowledge in the future, you know. That I see that as very important. And this I love quotes. So and you know, the more I have been working on this, the more clear for me it is that we need a new audiometry. And the conservative nature of audiology as a field has actually made it easy for me, because now it's so apparent that we actually need this. And there's a wide consensus amongst the PhDs in the field that the current audiometry is not adequate. We got clients lost in the system for years before getting the right diagnosis, if they ever get it. And that's not right. That's not how it should be. And therefore, I believe we need a new audiometry, and the time has come. Stronger than all the armies of the world is an IT, which time has come, and this it has really come. Victor Hugo said that. I love the name, Victor Hugo. So yeah, and I'm probably way over time. But for anybody interested in this project, please reach out to me, and because I need the ENTs and collaborators. You know, this is not right now my company. I'm a solopreneur. This is way bigger. So this is a kind of an invitation to collaborate on something that will affect 1.5 billion people in the world. So and it's not something that this affects us all. You know, we will all be in the group of people with a disabling hearing loss if we grow old enough. You know, there's no way around it. So this concerns us all, and I really think we owe it to the 1.5 billion people to make an audiometry that gives more answers and collect more information and is more relevant. Relevance is the key word here. I think I probably overdid my time, but I'm very grateful for this opportunity to present my work, and I'm delighted to.
It's a very perilous but a very rare condition. And presenting from a country like India, which is based in the tropics and is still developing, it is something that is very important for all otologists and otolaryngologists to keep in mind. The introduction. Otalgia is one of the commonest complaints that we encounter on a day-to-day practice. Studies have shown that about 10% of the world's population is bound to develop otalgia at some point or the other of their lifetime, and more commonly because of external auditory canal causes. It is mostly due to, just a moment. It is mostly due to either foreign bodies which have been lodged in the external auditory canal, or probably because of an infection, which is the otitis externa. So again, when we come to understand foreign bodies, they can either be organic or they can be inorganic. And among these organic foreign bodies, we commonly find flies, ants, nymphs, and of course, the most notorious ones being the ticks. called as otoacariasis. So heart ticks, ambyloma, are found in the tropical countries such as ours in India, Japan, Sri Lanka, Thailand, and Indonesia. They account to about 1% of the causes of ataxia in the population of all these countries, which is quite a lot of people. These are arthropods, and they're usually parasites which are living on cattle. So how do they come to lie inside the ear of a human being? So this is primarily because of having poor hygienic conditions or those who are working in close proximity with cattle, such as farmers, cattle rearers, those working in poultry farms, in whom the infested cattle are going to lead to the infection to enter into the person's ear who is very in close proximity. Then again, ticks cause several debilitating infections, and they're not to be taken lightly. They're known to cause Caisseneur forest disease, rickettsial fevers, Q fever, as well as Lyme's disease. So in the past decades, if you go through English literature, you feel that there are hardly about 10 or 11 cases of this otoacariasis that has been reported. So here we present to you one such rare case where we're trying to elucidate the approach to such a condition. So coming to the case capsule, we had a middle-aged female patient who was about 42 years old, and she was a farmer and a cattle rearer by occupation. She hails from rural Karnataka, which is one of the southern states of India. She came to us with complaints of right ear pain for about a week. It was sudden in onset. It was progressive. She also had a lot of scanty bleeding coming from that right ear. But she had no history of trauma. She had no history of ear discharge, nor did she have any history of reduced hearing. When we performed the initial examination, there were all features of otitis externa. She had tragal tenderness, she had swelling, she had severe pain of the ear. When we inserted the otoscope, she had a lot of congestion of the external auditory canal, and we could vaguely see a foreign body lodged in the posterior superior bony meatal wall. When we did a thorough examination with the help of an angled otoendoscope, we found what the image that is displayed over here. We found that there was a tick that was lodged in the canal wall skin. Surrounding the tick was a lot of ecchymosis, edematous skin, and the tympanic membrane, though it was not very close to the tick, seemed intact. There wasn't any perforation, nor was there any discharge coming from the middle ear. The mouth of the tick, as you can see, was facing away from the tympanic membrane or laterally. So this is again a detailed otoendoscopic view. You can see the ecchymosis. You can see the edema that has been caused over here. There have been previous attempts of cleaning the ear by the patient that has led to a lot of blood clots over here, but the tympanic membrane seems to be all right. When we removed the specimen and we further examined it under microscope to understand what it could be, we realized that there was a scutum that is being denoted by this green arrow over here, which is none other than the mouth. And over here, the hypostome. And then we have the legs that is shown by the red arrows. So when we understood its anatomy and we discussed with our colleagues in microbiology, we understood that this was ambyloma testudinarium. So how do we manage such a case? So the tick was first dislodged and we removed it using the Hartmann's forceps, a very important instrument that otolaryngologists should always have with him. And we must understand that this is unlike other foreign bodies. The tick with its mouth clings on and clutches onto the skin, making it a very painful condition. So we cannot afford to simply pull it off. We need to apply some topical anesthesia. So we use some 2% of lignocaine over here. And we then examined the remaining part of the canal wall. We used angle scopes to ensure that there hasn't been any nymph or eggs in the other parts of the canal. And then we thoroughly examined the tympanic membrane to ensure that the middle ear has not been infested. Following which, we did a thorough systemic examination so that we could rule out any systemic involvement, because several enzymes are secreted by such ticks, which can cause complications, including respiratory paralysis. Then we gave her a treatment of prophylactic antibiotics, some analgesics, as well as some anti-inflammatory enzymes. A prophylactic dose of antibiotics is very important because these ticks are not just parasites, but they're also vectors, which often carry a lot of bacteria. We come across a lot of scrub and tick-induced infections in this part of the world, and that is why we commonly prescribe such patients with broad-spectrum antibiotics, such as doxycycline, which is a tetracycline group. The patient and the attenders were then very thoroughly counseled regarding all the precautionary measures in order to prevent any future infestations. After 1 week and 2 weeks, when we followed up with the patient, she had a very clear EAC. There was no edema, there was no remnant infection, and she did not have any further systemic signs either. And the tympanic membrane was intact. She had no hearing loss and no vestibular dysfunctions either. So now that we were able to manage that case, coming to the discussion. Ticks are a group of organisms which are known as ectoparasites. They reside in the outer part of the body. They do not enter into the blood, and they're mainly hematophagous. So they basically feed on the blood of the mammal onto which they are infested. These are ranked second only to mosquitoes as vectors of human pathogens. So they carry and transmit pathogens such as bacteria, viruses, rickettsia, spirochetes, and protozoans, which is why we must be all the more cautious about such a seemingly simple infection. Tick-borne diseases are a form of vector-borne diseases which are a threat to both livestock as well as humans. The surge in the diagnosis of these diseases has contributed to not just a deeper knowledge and better diagnostic technique, but also because of a lot of urbanization and deforestation that is happening now, which has led to more interface for a human interaction along with fauna. So the chances of the patient getting infected by such an organism has become more. So within India, which is one of the tropical countries, as you know, there are certain areas which are very, very prevalent to have such tick infestations. One of them is the state where I'm presently working, which is Karnataka, wherein there's a district called Shimoga, which is very famous for tick-borne diseases. And we encounter Kaisenor forest disease, which is caused by the Flaviviridae group. We also have Crimean Congo fever, Q fever, rickettsial fever, and other such conditions. So now that we've said all of this and we've understood the gravity of these infestations, we must also know what are the various complications that they can manifest with systemically. So one of them is hemolysis. The patient could develop jaundice. You could see that there is a yellowish discoloration of the sclera, of the skin. The patient could have secondary fungal and bacterial infections. So more often than not, when this particular tick is infested onto the external auditory canal, especially if the tick is not an adult and it's in its nymph stage, when it has an engorgement following a blood meal, it sort of appears like a bleb of blood. So we might wrongly presume it to be some clot or blood or dirt, and we might just flush it out of the external auditory canal without properly examining the remaining part of the ear or the patient. But now we should bear in mind, because later the patient can come back to us with a secondary bacterial infection or a fungal otitis externa. The patient can also come back to us with systemic diseases. So if we do the primary evaluation properly, then it spares us the trouble of a difficult diagnosis at the later stage, because that time the treatment becomes more and more crucial. So now, though the oral infestation may not be an immediate emergency, we must understand one thing, that there'll be excruciating pain because the mouth parts of the organism are going to be clutching onto the skin of the EAC, which is very, very tender, which has a lot of rich nerve supply. So there'll be a large amount of inflammation and local irritation that it is causing. So it's very imperative that we quickly notice and also remove the infested tick from the ear, and also ensure that we give the patient a good amount of analgesia. The complications with respect to the ear have been described in several studies, wherein there have been cases where the tick has entered through a perforation in the tympanic membrane into the middle ear. A secondary infection following the tick infestation in the form of a chronic otitis media or suppurative otitis media has occurred. Sometimes the disease has progressed so greatly that it has led to vestibulitis or even facial nerve weakness because of ascending infection. Ticks release what is known as a neurotoxin. This neurotoxin inhibits the acetylcholine, and that is why it can even lead to respiratory distress or even paralysis. There have been case reports of the mouth part of the tick being attached to the tympanic membrane, leading to a perforation, and therein the release of the enzyme into the middle ear. And as we know, the middle ear cavity is very well connected with several other parts, and it's very easy for an infection from the ear to ascend into the brain or likewise into the blood. In this case, we did not encounter any of these grave complications, though luckily, because the mouth of the tick was facing away from the medial aspect and was facing externally or laterally. We also had no pre-existing perforation of the tympanic membrane. In this manner, it left the middle ear intact. So now we have to understand two important significances. One, the community perspective of health. Number two, the otolaryngologist's perspective. And lastly, the importance of systemic manifestations. So here, hygiene and awareness has to be instilled, especially among those who are representing the rural and suburban parts of developing tropical nations such as mine. So coming to our conclusion, otoacariasis, or the tick infestation of a human ear, is a parasitic infection that must be present in the repertoire of an otolaryngologist's mind. Though it might be a very overlooked condition, it can lead to grave otological complications, spanning from perforation of the tympanic membrane all the way to suppurative otitis media, can cause facial palsy, may even lead to labyrinthitis, which is a systemic complication, also such as hemolysis and even residency condition. The removal of the organism from the ear and a thorough local examination as well as a systemic examination is imperative. Alongside this, we must also educate the patient as well as their family regarding the various preventive measures and how the infection occurs, because we must make them understand that it is not just because of having an infection, but the infection has come because of being in very close proximity to cattle, which are themselves infected. So first, they must ensure that their cattle are healthy. They must ensure that the cattle has good veterinary support and care and be thoroughly checked for any form of parasitic infections. So this is just a note which I would like to share with all of you, though I know that not all of you are coming from countries such as mine, but to practice otolaryngology as a specialist, especially in a developing country, that too in the tropical regions of the world, we must remember one thing, that is the cure. And we must also very importantly remember the other thing, that is prevention, because prevention is always better than cure. This is the only way to help us reduce the morbidity and, of course, the unlikely event of a mortality from such rare parasitic infections. These are my references. So I would like to thank the Otolaryngology 2023 team from Dubai, UAE for this lovely opportunity, all my teachers and my guides for encouraging me throughout my career in ENT, and of course my family for the constant support in all my endeavors. Thank you, one and all.
Thank you, Lakshmi. Thank you for sharing your views on otoacariasis with us.
Middle third of the face, massive loss of middle third of the face. That was due to a camel bite. It happened to this poor patient about 300 kilometers south Cairo, and the patient spent 2 weeks in ICU. Yes. Before he came to our hospital. On arrival, the patient, I don't know how to proceed. Next slide. I would like to move the slide.
Okay.
Should I? Okay. Sorry for this interruption, but I can't move my presentation slide. Oh, it's here. It's moving now. Yeah, maybe. Yes. Well, this is the patient, and the patient on arrival was bleeding through the wound itself, and he had a gastric tube for feeding. The lost tissues included the nose, the cheeks, the upper lip, and the right eyelids. Both the maxillary bones, the vomer, and the hard palate, together with the right zygoma, were lost. A tracheostomy tube was put, and a free latissimus dorsi flap was elevated from the back and was vascularized with the left facial artery and external jugular tributaries. The flap was inset to build the roof of the mouth and to fill the gap and to cover the middle third of the face. After the free flap success, we planned to move 2 scalping flaps for the nose rebuilding and the upper lip reforming. The 2 flaps were received on top of the free flap just by creating local small hinged flaps on the top, on the skin part of the free flap to receive the converse forehead scalping flap to make to form a new nose with 1 nostril, a nasal shape, I would say. That was the scalping flap of converse, and it was received by the local flaps built on the latissimus dorsi flap, and the pedicle was divided 3 weeks after the transfer of the flap. To the right side, after division of the pedicle of the flap for the nasal reconstruction. Then the patient asked for a mustache, and I moved a right side opposite to the converse flap side, which was the left one. I used a right based extended temporoparietal flap, extended to reach the side of the upper lip and the mouth. It should have, it was extended, crossing the midline of the scalp to reach the destination. These are the front figures of the patient before the surgery, and a few months after the surgery, and 6 years later, showing good transverse and vertical heightness of the face, maintained setup. Because of the remained intact posterior walls of the maxillary bones, the maxillary tuberosities, and the left maxillary, the left zygomatic bone as well. Yet in the profile picture, we can see that after 6 years, the patient lost the projection of the formed middle third of the face due to the missed reconstruction of the anteroposterior axis of the skeleton of the middle third of the face, which is formed by the vomer and the hard palate. Despite this regression of the soft tissue reconstruction, the patient could be easier be socially reintegrated, and he went to his village and worked as a farmer, as he used to do that. In conclusion, reconstruction of the middle third of the face should essentially depend on the 3D construction of the skeleton of the face. Thank you. I finished the presentation.
Thank you, Ahmed.
You
I
are
hope
welcome.
it would have been a remarkable experience. Yeah, thank you for sharing it with us.
Thank you.
Are there any questions for Dr. Ahmed with regards to this presentation? Okay, thank you once again.
You are welcome. Bye-bye.
Yeah, it's my pleasure. Yeah, thank you.
أقفل واطلع ولا إيه؟
The next presentation will be from the presenter, Dr. Maria Naguer from University of Campinas, Brazil, with a presentation entitled The Effect of Cryo-Stretching and Massage Therapy on Mouth Opening After Oral Neoplasia. Miriam? Yeah.
Hi. Okay. Good afternoon, everybody. Firstly, I would like to thank the organized committee for the invitation. I'm from Brazil, and this is the university where I work. You can see?
Yes, we can.
Okay. The Campi is a public university in Brazil. In the research, it's considered the second best in Latin America. My name is Professor Dr. Miriam Nagai. I am Associate Professor in Campinas University, Orofacial Motricity Specialist, teaches classes in undergraduate course in speech therapists and postgraduate program in health, interdisciplinarity and rehabilitation in medical faculty science. Studied therapy to dysfunction in head and neck muscles with surface electromyography since 1992. I will talk about the effects of cryotherapy stretching and massage therapy on mouth open
Miriam?
after. Hi.
I'm sorry for the interruption, but your slides are not moving. It's still in the first slide.
Sorry. Now, okay?
No, it's still in the first slide, the same. Can you click on the second slide? It's still on the first slide.
Now, okay?
No, still the same. Instead of clicking the right arrow button, can you click on the second slide?
Okay?
No. Could you able to send us your PPT, Doctor, so we could share on our behalf? Or else kindly click on the slideshow option, which will be below.
Sorry.
Not an issue.
You can see?
Yes, but we could see only your first slide, the campus of the Campinas University. Yes, we could just see that slide.
You can see this?
No, still
No?
on the same slide. No.
I will try again.
You could share your PPT with Miss Rebecca through WhatsApp.
Okay. Okay.
Yes, and she will share the PPT for you. And
I
we'll
can
wait until
see
then. Yeah.
I can see after, okay?
Yes, okay, no problem. You can
Okay,
share your
okay,
PPT with
okay.
Miss Rebecca through WhatsApp, and then
Okay.
she'll play the PPT.
Okay, okay.
Yes,
Sorry.
no problem. Not an issue at all. We will wait until that for you. Okay?
You can a presentation other people is better.
Okay, yeah. We shall now have a video presentation of Dr. Stefan C. A. Hegman from Balance Clinic, Switzerland, with his presentation entitled A New Hypothesis on the Pathophysiology of Meniere's Disease. As Dr. Stefan could not able to join us, we'll have a video presentation for him.
Olivia, please, next. Specialist teaches class in undergraduate course in speech therapist and postgraduate program in health, interdisciplinarity, and rehabilitation in medical faculty science. Studied therapy, dysfunction in head and neck muscles with surface electromyography since 1992. Next, please. I will talk about the effect of cryotherapy stretching and massage therapy on mouth open after oral neoplasia. This is the patient post-neoplasia oral with trismus or restriction of mouth open. Next. And here we can see the neoplasia process. And number 1, normal cells. Number 2, cell division. Number 3, cells mutation due to the etiology of alcohol and tobacco. And number 4, disorder reproduction. And finally, in number 5, the cancer, the presence of cancer. Next. And here, the main site of the tumor and the retromolar trigonum. Please, next. Surgery is a radical treatment that removes the tumor and when indicated, removes the lymphatic chain of lymph nodes from the primary tumor's host organ. Radiotherapy eradicates the tumor using ionizing radiation, but causes damage to local and surrounding healthy tissues. Next, please. Sample characterization. 16 patients awaiting dental prosthesis or complaint of trismus after chemotherapy and radiotherapy treatment due to oral neoplasia. Initial stage of disease E1, 2, 3, and 0 to 2, and only 0. Patients who have been discharged and no neoplasia. Next, please. Therapeutic intervention. 15 sessions were held over 3 months, maneuvers. According to the literature, this time is the minimum established so that morphological changes in muscle fiber can be consolidated. Was performed once per week and the mouth open. Records with electromyography were collected at the beginning and the final of treatment. Next. The results show mouth open was measured in all sessions, and it was possible to prove not only progress, but also absence of recurrence, with significant difference pre- and post-treatment. Next. Massage therapy on the third day after surgery improves movements, making patients have reduction and deformities and best circulation. Studies how Calenda and Winch claim that massage therapy can reduce pain and tension levels caused by neoplasia treatment. Next. Massage therapy. Circular massage was performed and digital pressure in the belly and insertion muscles, masseter and supraioides, 4 times in each muscle, totaling 15 minutes. Next. This is the local with message in the villi and the insertion masseter muscles. Next. Water ice cubes with dimension of 3 centimeters tall and 4 centimeters width, wrapped in gauze, were positioned in masseter muscles and posterior in supraoid muscles for 60 seconds with interval of the 15 seconds until for the patient to report analgesia in the area. Next. The cryotherapy in masseter muscles. Time intervention was 50 minutes. Next. Cryotherapy in supraoid muscles with time intervention was 50 minutes too. Next. Sorry, but several friends don't
My name is Alejandra Arellano Bárcenas. I am otorhinolaryngologist and head and neck surgeon, and I work in the public practice in Extremadura in Spain. Let me introduce myself. I studied medicine in Mexico. After I studied the specialty of otorhinolaryngology and head and neck surgery in Mexico also. After I made an international master in nutrition with a specialty in eating disorders. I am recertified by the Council of Otorhinolaryngology in Mexico and in the College of Physicians of La Rioja in Spain. I made pediatric attendance at the service of otorhinolaryngology at Mayo Clinic in Rochester, Minnesota in the United States, and the University Clinic of Navarra in Pamplona in Spain. Now I am working like otorhinolaryngology and head and neck surgeon in the Hospital Ciudad de Coria in Extremadura in Spain. During the pandemic, I was working in the COVID critical area in Mexico. I am professor of otorhinolaryngology at the Faculty of Medicine in the Universidad Anáhuac and currently at the Anáhuac Otorhinolaryngology undergraduate program clinical sessions by internet. I have publications in national and international index journal of otorhinolaryngology, and I am author of chapters in book of the specialty. I am member of the editorial board of International Journal of Otorhinolaryngology, and I am reviewer for the publication in the Cuban, in the journal of Universidad Anáhuac and in the Cuban Journal of Otorhinolaryngology and head and neck surgery. I would like to mention first that I have treated 4 to 5 pediatric patients with tinnitus in the last 10 months, and which is why I was concerned about doing this review. First, I would like to tell you that we define the tinnitus as the perception of a sound in the absence of an external source, and it is inaudible to the environment. This is a very frequent symptom in the practice of otorhinolaryngology, but here the question is how frequent is it in the pediatric population? And trying to answer this question is difficult because there are few reports on it. It is estimated that between 13 and 47 of normal hearing children complain of the symptom. And if we are talking about hearing loss, it is reported about 55% of the cases. And the tinnitus can cause from minor discomfort in some infants to difficulties in concentration, stress, fatigue, irritation, sleep disturbance, learning impairment, inattention, and emotional distress. And we can divide the symptom in two large groups. The first is subjective, and in here there is not an external stimulus that produces it, and isn't perceived by others or by the examining physician, and it corresponds to approximately 95%. And the other group is the objective. It is perceived by the examiner and corresponds to 5% more or less. And unfortunately, we don't have clinical guidelines to the treatment of children with this symptom. Likewise, there is a lack of methodological standards and outcomes measures to assess the clinical and impact of the symptom in the pediatric population. And the pathophysiology has been tried to explain based on the knowledge that we have in the adults. And tinnitus is, we know that the tinnitus is a result of an abnormal activity in the auditory pathway that can occur in any point on it. And since the pathophysiology of this symptom is very complex, and for this reason we have multiple theories that have been generated to try to explain the symptom. But we have new studies that reveal that the alteration in the compensation symptoms of the central auditory pathways as a determining factor in the chronification after an aggression, mainly peripheral, and in many cases this aggression occurs in the cochlea. And talking about this cochlear alteration, I would like to show you this picture, no? And about the cochlear alteration, this theory talks about an alteration between the functioning of the external and internal hair cells that we can see here, our internal and external, and where the degeneration of the external here hair cells will generate a collapse of the tectorial membrane here in purple, producing a chronic depolarization of the internal hair cells, thus generating a normal activity in the afferent pathways. And we have another important theory. This theory talks about in alterations of the metabolic cycle of glutamate. And I'm going to show you the picture to explain this theory. And we are talking alteration that happens in the synaptic ribbon. We can remember that this kind of synaptic is a very fast, and it is present in the eye, in the ear, and in the vestibular system. This the alteration in the metabolic cycle of glutamate, either due to excess release or lack of reuptake and metabolism, which will produce a state of continued depolarization and depolarization of the afferent pathway, causing cell edema, release of metabolites of oxygen with apoptosis. And we have a high association of the symptom with hearing loss, which is reported in up to 50% of cases. And it is justified by making a similarity that happened with the reorganization that the somatosensory cortex undergoes after the amputation of a limb, that we call the limb phantom. The areas of the auditory cortex that lose the afferent innervation will undergo reorganization and will perceive anomalous auditory sensation that will be experienced as tinnitus. And talking about the etiology, we have different possible causes of the symptom that can cause the symptom in the childhood. For example, viral illness, viral infection, otic pathology, for example, acute and serous otitis media, tympanic perforations, contraction of the ossicular chain and palatal muscles, eustachian tube dysfunction, etc. Also exposure to acute trauma, earwax loss, head trauma, ototoxicity have been reported like etiology. And if we have a patient, a pediatric patient with the symptoms, we need to make a complete clinical history with a special emphasis on the semiology of the symptom, accompanied by an exhaustive general physical and otorhinolaryngology examination with performance of tone audiometry, log audiometry, impedance tympanometry, tinnitus measurement. We think that if necessary, could be necessary according to the clinical judgment. We need to make otoacoustic emissions, evoke potentials, computer tomography, and nuclear magnetic resonance. And talking about the treatment, this is related to the etiology and includes sound treatment, for example, tinnitus retraining therapy, psychological treatment, pharmacological treatment, physical treatment, for example, hearing aids, and surgical treatment. And fortunately, it has been documented that childhood tinnitus, in many cases, is self-limited and has a better prognosis than in adults, getting the right treatment, of course. For this reason, it is likely that it has a greater chance of improving only with counseling or with a combination of therapy without surgical treatment. And for conclusion, I would like to mention that, as we have documented, there are field studies and monitoring of tinnitus in children, with a large area of study still to be clarified. Here you can see the references. And thank you very much for your attention. And here you can see my email address if you want to make an answer and a question or a comment. And only I would like to tell you that at the beginning of the conference, I told you that I have treated 4 to 5 pediatric patients with tinnitus in the last 10 months. And the etiology were external otitis and eustachian tube dysfunction. And after getting the right treatment, the symptom disappeared in the next 3 months, more or less. Thank you very much for your attention.
So, as we all know, the prevalence of early childhood caries was reported quite high in many countries, including Malaysia. The humoral immunologic response can regulate caries, especially salivary IgA, which has immunological control over dental caries. There is an association between the caries and the increase in the level of salivary IgA, which may be due to the response to the mild exposition of dental caries as a form of protective mechanism of the body against the caries attack. So still, this relation between salivary IgA and dental caries is controversial and need further investigations. And that's what we will talk about in this lecture. So, clinical studies of the oral disease in relation to salivary constituents are usually complicated by the difficulties in standardizing sampling method, laboratory tests, and contribute to diversity of findings. So, the salivary component and the value found for their concentration, the data should be interpreted cautiously once the antimicrobial capacity of this passive component is not necessarily related to its concentration in the saliva. So the concentration of salivary constituents are regulated by different factors, including the salivary flow, which is hard to be measured at that age. The early childhood caries is one of the major public health problems due to high prevalence in all regions of the world. The etiology of the early childhood caries is similar to other types of dental caries, but its biology may differ in some aspects, considering that the bacterial flora and the host defense are not completely established in those children, and the surface of their erupted teeth are still immature. So since the microorganisms like the Streptococcus mutans are one of the main etiological factors of dental caries. Immune There are the early childhood caries considered as multifactorial disease associated with different factors like inappropriate feeding pattern, high carbohydrate consumption, poor oral hygiene measures, the transmission of infectious microorganism from caregiver to the infant, dental hypoplasia, malnutrition, low socioeconomic status. All of these are may contribute with this disease. While dental caries is defined as a localized post-eruptive pathological process of external origin that involve the dissolving of the hard tooth tissue and progressing of the formation of the cavity. So it's considered as the most common childhood chronic disease in age between 5 to 17. And is 5 times more common than asthma or severe, and 7 times more common than hay fever. It's a multifactorial disease, and it affects 60 to 90% of school-age children worldwide. Also, there are other factors which are really concerning and really involving in this and influencing the dental caries, which are the genetic and environmental factors. Because genetic differences in certain environment factors tend to be more cariogenic for some people than others. Saliva and its components, immunological and non-immunological, as host factors may play an important role in maintaining oral health. Salivary components, their flow, viscosity, buffering capacity, play a major role in the prevention, initiation, and the progression of the disease. It helps the prevention of caries through the antibacterial effect. Well, the saliva, as we mentioned, usually play a very special role in maintaining oral health due to, as we mentioned before, the factors that it contain, and it controls the metabolism, adherence, growth of the pathogen, improves the removal of carbohydrate residue, provide tooth remineralization, and neutralizing organic acid produced by acidogenic microorganism that may lead to tooth demineralization. So the salivary IgA contributes almost 60% of the total immunoglobulin count of the saliva. So the salivary immunoglobulin rule is in the protection against dental caries. This has been investigated in several studies, but making this associated would be complicated, since there are many different sampling method, different criteria, different patient group, and different laboratory tests. So the concentration of salivary immunoglobulin may depend on the salivary flow rate, hormonal factors, emotional factors, and even physical activity. These immunoglobulins can inhibit the attachment and the adherence of oral bacteria to the epithelial and tooth surface. They neutralize viruses, bacteria, exotoxin, and enzyme that contribute to the disease process. They prevent both non-specific and stereochemical interaction, and therefore interfere with the bacterial adhesion to host surface. It's the first line defense. However, when a load of microorganism is high, more salivary immunoglobulin production is not able to prevent the disease. So it is considered a salivary indicator of dental caries activity. Salivary IgA titration level, as considered as a diagnostic tool, has largely been explored for both unspecific and specific salivary IgA. In general, the secretory immune response in microorganism specific, in addition, this local sensitization can lead to a cross-reaction epitopes which potentiate the response. The exposure to cariogenic microorganisms or microbiotics leads to secretion of immune component against several microorganisms epitopes, which initiate the primary immunological response. One theory suggests that the binding reduce the free salivary IgA in the saliva from caries active subject in comparison of caries resistant one. Some author reported high level of salivary IgA in caries-resistant individual in comparison to caries-susceptible one, suggesting an effective protective function of immunoglobulin. So host genetic defenses and their phenotype affect the saliva characteristic and can be reasonable explanation for why some children develop caries even if they have good dietary and hygiene habits. Important metabolites of the psychologic system to determine the state of health and disease for both oral and systemic condition, and the salivary gland provide the most important source for salivary IgA in the upper tract, and many factors can influence its concentration. So, the question that will arise from the beginning is what's the relation between salivary IgA level and the presence of dental caries? Many scientists go through these subjects. These are some of the examples of previous studies went through this. Some of them, but the results that they got and the conclusions that they got is controversy. Some of them reported that there is association between the elevated salivary IgA and increased caries activity. Some indicate that the mean salivary IgA was significantly higher among early childhood caries group. Some reported an inverse relationship between salivary IgA level and caries experience in children, especially at the age between 3 and 6. And some provide that there is no correlation between salivary IgA and the early childhood caries. Others mentioned that salivary pH, flow rate, buffering capacity, protein concentration, and other factors in the saliva may give impact to the incidence of caries, reporting an increase in the level of salivary IgA with decrease in caries activity. So, the salivary IgA can be one of the biomarkers for caries. High level of salivary IgA indicate a higher caries risk. It's then supported by the alteration of salivary flow rate and salivary pH. By knowing these parameters, the dentist has good indicators that can be used in preventive measures for dental caries. This study was to assess the level of salivary IgA in unstimulated whole salivary sample of both caries-free, caries-active children and to correlate the role of salivary IgA in the prevention of dental caries. Early detection of dental caries will help in providing necessary oral health risk. Is then supported by the alteration of salivary flow rate and salivary pH. By knowing these parameters, the dentist has good indicators that can be used in preventive measures for dental caries. This study was to assess the level of salivary IgA in unstimulated whole salivary sample of both caries-free, caries-active children and to correlate the role of salivary IgA in the prevention of dental caries. Early detection of dental caries will help in providing necessary oral health preventive service and specific program for children to protect against dental caries. So we need to know exactly which to follow, which idea, although you will see at the end of the day, each one have their opinion in this case. So 36 subjects or 36 children were involved in this study in age between 2 to 5 old years. And they were divided into 3 groups, caries-free, early childhood caries, and severe early childhood caries. According to the following inclusion and exclusion criteria, we include them, and we exclude patient with congenital abnormalities, patient on chemotherapy, radiotherapy, patient with mental problem, patient on antibiotic for more than 3 months, patient on chronic medication, which may cause hyposalivation, and patients who suffer from upper respiratory tract infection for the last 2 weeks. These are some of the protocols to be followed during the procedure of collecting the sample. And investigation and the measurement of salivary flow rate and the analysis of the salivary IgA. From the results, we can see that salivary flow rate is higher in the median in severe early in these cases, and we can compare it to the salivary pH, and we can see clearly that the level of salivary IgA is much more higher, significantly higher in early childhood caries comparing to the caries-free and the severe early childhood caries. So here we come to our conclusion and discussion regarding this matter. It's important to consider the complex background of early childhood caries and the many ways in which immunologic and non-immunologic factors can interfere with the disease. So children with early childhood caries are infected with high level of Streptococcus mitis, which are generally acquired from their mothers at early age. The pathogenic microorganisms associated with frequent carbohydrate intake produce organic acids that lower the pH of the dental plaque, leading to demineralization of the teeth. So according to the result, there was a significant positive association between the concentration of salivary IgA and the presence of early childhood caries. We find out that high concentration of salivary IgA in children with early childhood caries can be associated with an increase in antigenic load, which lead to high production of antibodies. Since early childhood caries is a disease that include an immunological response, antibody titers in children with carious lesion should present different concentration from a similar group of children without dental caries. So the salivary IgA would not be related to direct protection against dental caries, but would reflect a past exposure of host to cariogenic organisms. In the absence of continuous stimulation, which does not happen during the natural progress of dental caries, the immunological titer would tend to decline, which seems to be characteristic to the immunological system. So as a conclusion, these obtained results allow us to consider that the presence of early childhood caries was associated with an increase in the total salivary IgA, and the salivary IgA has a protective mechanism against dental caries in the whole saliva of children with early childhood caries. So the salivary IgA antibodies can play an important role in control of dental caries. Of course, longer-term studies should be carried out in this field just for investigating more on salivary IgA and dental caries from different aspects. This for sure will improve the oral health prevention program, aiding to early detection of dental caries. With that, thank you.
If there are any questions with regards to this video presentation, we request you to kindly drop them in the chat box, and the queries will be forwarded to the
you can find that in those papers, the procedures the surgeons are performed without these considerations, they leave a patch appearance that looks so bad on the patient even months or years after the procedures. It's for that reason I decided to revisit this important topic in plastic surgery. Oh, wait, I can. Okay. I can, the next. Okay. This is the agenda I'm going to follow at this moment. This is the point we're going to subject at least. The background. For small defects, you can follow the lower skin tension lines, but when you have bigger defects or small defects but with this anatomical distorting, you can follow the subunit or unit facial aesthetic units or subunits. The first one to introduce the concept was González Ulloa, who was a plastic surgeon from Mexico. He published this article in 1956. He showed us the aesthetic unit of the forehead, or the nose, or even of the cheek. But there were another surgeons like Ralph Millard or Sir Harold Gillis who followed them. He took this consideration on the reconstructions, but were Frederick Menick and Bourget who introduced the concept not only the aesthetic units, the facial aesthetic unit, but also the nasal aesthetic subunits. And even the considerations for the forehead flap, which is the workhorse of this kind of reconstructions. This is an article I published about facial aesthetic according to aesthetic units, and this is about principles. I had the opportunity to participate in a webinar with Dr. Frederick Menick, who is the master of the nose reconstruction. This is an observational, retrospective, and descriptive study. A total of 60 patients with lesions on nasal skin cancer were included on this, and the lesions were confirmed with previous cutaneous biopsy. This is talking about a forehead flap, one stage, two stage, but also in patients who decided to do one stage and doing another procedure, for example, nasolabial flap. The cases, for example, this is a sidewall defect with a basal cell skin cancer. In one stage, we did the remotion of the lesion, we draw the subunits of the subunits of the nose. We did follow the line, the dotted lines, do the cut, the remotion, and this is a control the patient after the procedure. This is Ella nose basal cell skin, no, it's a ischemic cell cancer. We do the remotion, we draw the lines. On this case, we also did a nasolabial flap. We reconstruct the ala, and this is the control of the patient after the procedure, 4 or 5 months after the procedure. This is a case of melanoma. We show in the paper. Did the remotion of the nose. We usually do a stir strip of the nose to cover and draw the lines of the subunit, the nasal subunits to project that design over the forehead. And this is the second. This was a two-stage procedure. I would like to do another one because it would be better for the patient, but she refused to do it because the age of the patient, and she went from the interior of the country. This is the result 1 year after the procedure. This is a two-stage procedure with our motions, basal cell skin cancer. This is the result after the first procedure. You can see the video, I guess. We take care about do the breathing incision with the triangle in the posterior. In order to avoid the line, I'm gonna show you one complication I had because I didn't follow this suggestion. This is the cut, after the second one procedure, the remotion of the tip, the detachment of the flap, sorry. And this is the result. To consideration in this case, you can follow for example, I respect, when I do the remotion of the tip, I respect the soft triangle bilaterally, and I do the red incision with the triangle, superior triangle, to avoid the line and avoid the notch you can get when you do this without this consideration. This is the result of the patient after 1 year after the procedure. On this case, this is another case important, basal cell skin cancer. You know, for the reconstruction of the cheek, you have to choose cheek, and to reconstruct the nose, you have to use frontal forehead flap. This is the flap to the procedure. The second one procedure, put the flapping, no? And this is the result. And the other result is the detachment of the flap. This came from Florida. He had the dermatologist did the surgery, with the most surgery to remove the basal cell skin cancer from the tip of this patient. And this is the pictures on the cabinet of the doctor. And this 11 years after, he came to my office with this defect. And we did the remotion, draw the lines of the subunits, put the story sheets of the patient, draw the different subunits over there. And this is at the end of the first stage. This is the picture before the second stage. And the second stage, we detach the flap, do the reconstruction of the structures. I use the cartilage to do the structure of the nose. This is where the cartilage in the position, covered again with the flap, and the detachment of the flap, the final stage. This is the patient one day after the procedure. This is a picture he sent me from, it was in the pandemic times. This is a control of the patient, this is the result. Not one patient with the 3-stage procedure, we remove the nose. Because in this case, his skinhead doesn't problem with the expansion. We have no problems with that. This is at the end of the third stage. I did the structure also. We have good procedure. But I found this article, 2023, where you can find one more step to produce a very good result, especially in the increase of yellow. We have also had this kind of defects. We have to correct we need to close this kind of defect. We need 2 layers. First, I did a foreign flap with the remotional flap, leave this, and we're gonna do another procedure, a 3-stage procedure of medic on this patient in the future. But at this moment, we have closed just the defect. Complications, I have, for example, in this case, 62-year-old man, I did the remotion of the flap. We do the design of the subunits of the nose, cover the defect, but I had but I had the asymmetry of the nostrils. But this is a defect that the patient was happy with the result, but for me, it's really important to conserve the symmetry of the nostrils or the nose or whatever we do in plastic surgery. This is a guy I did the surgery 8 years ago. I found him 1 year, 2 years ago. I don't remember, I have the picture, but the patient didn't want any other procedure. He was happy with this flapping, B-flap. I wanted to correct the nose defect, but he didn't come back never. And when I asked him about the possibility to do another surgery, he told me, I am happy with the result. Well, so patience. This is another case where I did a mistake. I told you about the necessity to do a thread incision to avoid the notch here also, in the columella. I did a remotion on the patient, and I committed another mistake. I didn't do a structure in this case. I thought because she had a thick skin, it would be enough to correct the ala, but we have a traction and another cicatrization. The healing was not good for me, and you have two problems on this nose: the notch here on behind and the columella, and the symmetry and the no good structure of the nose because we did not structure, no correct with air cartilage. It would be necessary to do this is not 3-stage, sorry, it was a mistake. It's 2-stage procedure with a not good result. Another one I did, this is the patient with, this is the 2-stage procedure also, but I committed a mistake. I thought it was the flapping we had in this case, it would be better in the current month after the procedure, but we have this, especially on the left side, on the right side, sorry, on the left pictures, you can see the thickening of the flap, which is not improved a lot after the procedure. For that reason, I decided to do this kind. What happened on this case is important to understand. When you cover the dorsum of the side wall of the nose, you use this part of the flap, which is containing the gallia, because it's the normal procedure for the flap. Normally, you're going to have a thick flap. It's important to do the second one procedure to thinning the flap. This is the example of how do we do, because we use just in the middle of the flap, you're going to have the gallia also. But when you reconstruct the tip, the ala, you use the subcutaneous dissection of the flap in the distal dissection of the flap. This is not cancer, it was Judah, yeah, leishmania, and you have this patient without septum, without and I did first of all microsurgery warm flap. I did not the microsurgery. There is a doctor from Peru, Dr. Anaya, who helped me with the microsurgery in my cases. I do the remodelation. This is my job, to do the remodelation 20 days after and reconstruct the septum. And finally, I did a 3-stage foreign flap, the second procedure with the rib grafts, and the first one procedure, the second procedure, and the detachment of the flap with this formed nose. What happened here? Even I asked Dr. Manning about what happened in this case. He told me the problem here is you didn't remove enough skin to cover the defect and to do the lining of the nose. For that reason, we had a collapse of the nostrils of this case. This is one case not from the work represented in the paper, but I wanted to show you. I have time. This is lymphoma, lymphoma problem. She had a problem. We did also microsurgery for flap, skin, the rib graft, promotion. We had an infection of the rib, but this is the first one, third procedure. We use the Doppler also to be sure about the circulation. and this is a flap. In this case, why I present this case as complication, because we need another more than the skin. The skin we harvest is too much from the. It's gonna take so long to close the defect in the first. In the construction. The detachment, loop had an infection, is the patient. We need to more procedures on sure, I guess. And one here because one procedure, 22 stage 7%, and 3-stage procedures, and microsarcopenia, whatever, 28%. The more common defect, the pathology, according to pathologic diagnosis, 87%, as we can wait in this kind of research. Basal cell skin cancer, 87%, squamous cell skin cancer, 12%, melanoma, less than 2%. The more common subgenital effect was 21 and no more than 22%. I found this paper where 20 expert surgeons in facial reconstruction are asked about what is the best option for them to close the different facial defects. Underlined, you can find the nasal defects. It's important. You can see the most of them choose rigor, limber, nasal label, by lower double transposition, lateral basement, east-west, reverse CPR, but no one choose the forehead flap because it's very laborious. No, it's important to consider that. When I started this talk, I told you about the necessity to revisit this important topic in plastic surgery. Regardless of the number of procedures you have to do on each patient, it's important to choose our best option to allow them to recover their normal appearance and therefore their normal lives. Thank you very much.
Common cause of chronic nasal. Many techniques have been used to reduce the size of the turbinates, such as extramucosal or submucosal excision, galvanocauterization, radiofrequency, collator, laser, etc. All of them with the purpose of expanding the air passage through the nostrils. Justification of the technique. The application of laser in hemangiomas, Rendweber osseous disease, and others requires the application of cold to the surface to be treated to reduce the circulation of the chromophobe hemoglobin. You can see these pictures where the hemangiomas are in the mouth and the endooral mucosa. After the laser application and before laser application and after laser application. The results are excellent. Based on this principle, cold was applied to the turbinate to prevent the spread of heat beyond the point of application. Objective: to present a technique that simplifies the application of laser in patients in the office with local anesthesia. Previously cooling the inferior turbinate to eliminate damage beyond the site of application due to chromophobe circulation at high temperatures. Indications: inferior turbinate hypertrophy and vasomotor rhinitis. Methods. The technique begins with the application of topical anesthesia. First, cotton swabs soaked in lidocaine 10% and oxymetazoline are placed 4 minutes in nasal cavity. After that, second, the swabs are removed and new ones are placed 1 minute with adrenaline 50%. The swabs are removed and tato type cryo is applied to the medial surface of the lower edge of the inferior turbinate 4 minutes using carbon dioxide as a freezing agent which produces 4 degrees Celsius below zero. By video endoscopy will show the channel left by the application of cold. The channel left by the application of cold. Diode laser is applied through the frozen turbinate channel from the back to the front of it. It is not necessary to leave splints, no synechiae formation occurs. The laser acts on the chromophobe hemoglobin. A chromophobe is a molecule that selectively absorbs laser with a specific wavelength for that chromophobe. The absorbed light alters the hemoglobin permanently. By acting on the chromophobe hemoglobin, the laser transmits its temperature, 800 Celsius degrees, to areas beyond the application zone. By using cold in the surgical area, distant injuries are avoided. Necessary equipment for the cryotherapy prior to laser. Tato del cryode for nasal cavity, designed by Professor Juan Manuel Tato, Argentine. This is the cryode and a specule to protect the nasal vestibule from the cold, and cryotherapy device. The cryode model has two ends. Usual distal end without average, and proximal end covered by Teflon, that is Iceland. And 3, the specule for nasal passages. The distal end without any coverage, centimeter. Carboxyl dioxide cryotherapy equipment that is capable of producing 4 degrees Celsius below zero, and safety glasses to protect the patient eyes from falling dry eyes during the procedure. It can be done under local topical anesthesia with patient without needles. Swabs with lidocaine 10% plus oxymetazoline are placed 4 minutes. After that, swabs with adrenaline 50% are placed 1 minute. To be operated on hypertrophies of the posterior end and inferior border of the inferior turbinate. The heel of the inferior turbinate is located to avoid it. Shower turbinate after removing swabs with 50% adrenaline for 5 minutes. As you can see, as you can see, inferior turbinate is collapsing. Cryotherapy useful application, 4 minutes. We can insert the cryode model Tato inside the nasal fossa, the nasal cavity, and protect the nostrils, nasal vestibule with, this is the cryode outside the patient, and the equipment, cryotherapy device, that has legal that they show the temperature. The cryode is applied against the convex sides of the inferior turbinate near its inferior border. The insertion depth will be 6 centimeters from the nasal valve to reach the posterior end of the turbinate as the tail of the turbinate on the cone. The cryode freezing, and the speculum on the nasal vestibule. After 4 minutes of the exposure to 4 degrees Celsius below zero, the cryode heating cycle begins to be able to detach it from the turbinate, since it adheres strongly to the cold. Video endoscopy confirming the effect of fall in the inferior turbinate. A frozen depression channel or canal is seen on the medial surface of the turbinate near its inferior edge, surrounded by dry ice. The video shows the channel or canal, the dry ice, from head to tail. We can see the canal along the turbinate. This is very important to understand this procedure. The same, the channel from the head to the tail of the turbinate. After that, the application of diode laser is carried out using a 400 micron optical fiber with handle. The handpiece, the fiber is 400 micron, and the optical by video endoscopy. You can see now the left nasal cavity with the laser with previous cryotherapy. You can see the cavity, the channel of canal with the laser fiber acting on it. And there, the right nasal cavity, laser without previous cryotherapy. It is more difficult. Therapy, channel, and laser. Advantage of cryolaser turbinoplasty. 1. Delimit the path of the laser diode terminal. Reduce the volume of tissue to be treated by collapsing it due to freezing. Reduce the application time intensity in watts of the laser. The frozen tissue is anesthetized and facilitates the application of laser in the weight patient. Prevent the spread of chromophobe hemoglobin to damage the rest of the turbinate. The work compared 30 turbinoplasty resective endoscopic surgery, 10 diode laser turbinoplasties, and 10 cryolaser diode turbinoplasties. The following methods were used for the diagnosis and inclusion of cases: nose scalp, videorrhopy to evaluate nasal septum and turbinate components, and feasibility of applying the cryolaser. Rhinodebito only patients who to oxymetazoline were included. The nose scalp that measures nasal patency, usually now it. Results. The functional results were similar in both laser groups, laser without cold application and laser with prior cold application. All patients reported breathing well and comfortably from the 6th day of the procedure and thereafter. The advantage of cryolaser turbinoplasty were better video endoscopy vision, reduced humidity in the nasal cavity due to freezing, and offers more space to slide the optics. Total improvement of local anesthesia since it works with frozen tissue, achieving a comfortable application of the diode laser. Prevents of spread of the laser effect beyond the application site due to freezing. There was no bleeding during and after the procedures. There was no formation of synechiae in the long postoperative period. Low scab production compared to other methods. Better handling on the laser diode terminal, which runs through the cryosurgery channel that guides the laser fiber. Reduction of exposure and intensity in watts of laser due to the marked reduction of tissue to be treated. All turbinoplasties performed with cryolaser had good results in terms of nasal patency. The procedure was very comfortable to perform under topical local anesthesia, using lidocaine 10% added with oxymetazoline and adrenaline 50% after. With the previous use of cryotherapy, the application of the fiber that conducts the laser through the channel that generates the cold was easy. The postoperative period was shorter than with laser alone, absent of hemorrhages and turbinoceptal synechiae. Thank you for your attention. This is my WhatsApp number.
Thank you, Leandro. Thank you for sharing your valuable research work with us. Are there any queries with regards to this presentation?
Good results. We work obviously as a team, and we like to improve the results of aesthetic surgical facial procedures such as facelift, blef, frontoplasty, rhinoseptoplasty, among different energy-based devices such as lights, lasers, or another therapies that I will show you. Powerful and with multiple benefits procedures, you can use surgical. Sometimes it is expensive and you need a lot of blood in an important way. We have an indication for this as a pigmentary pathologies, vascular pathologies, or skin rejuvenation, in order to improve the textures and the lines and fine wrinkles of the skin. What we have? We have different devices with IPLs, low-level laser therapy, different kinds of lasers, and we use a lot of CO2 and erbium YAG lasers, non-ablative lasers, and micro frequency, and HIFU, high intensity difference, because one is monochromatic, the other one is polychromatic. So IPL is going to target more things than lasers. Lasers are coherent and IPLs are uncoherent. And it's very important to know the collimated lasers and the IPL are divergent. So IPL, as I said before, contain powerful flash lamps that produces light. It's polychromatic between 400 and 700 nanometers, and it can achieve the infrared 1200. It's non-current, non-collimated, and the pulsation duration is between 1.5 and 200 milliseconds. So in these cases, for example, when we have a surgery, we can prepare the patients with, in this case, we have an exflame and rosacea. In our practice, we do a lot of rhinoplasty, and it's very important to control rosacea and acne before the surgery. So all the patients, it's going to be beneficiated of these procedures. Here we have one treatment 1 month later, and with light and polarized light, and we can see how the texture and the color of the skin is improved. Low-level laser therapy is a new kind of light. We have red lights, blue lights, and yellow lights. Red lights is very anti-inflammatory. Blue light is antibacterial, so in acne is very useful. And yellow light it works for stimulate for neural. So in facial palsy is very useful as well. Here we can see how we put to the patients. We use normally after the surgery. For example, if we do a BLEF and with a peri-orbital rejuvenation, after after the surgery, we use the red light in order to manage the inflammation. In this case, we have a burn with hot wax, and only with 12 treatments of red light, we can see the improvement after 2 months. Erbium glass is a non-ablative laser technology that penetrates the skin, and when we have a trophic scar or like a volcano, like a crater, we can refill that skin with this kind of lasers. So it's very useful for scar treatment. Here we can see how only with this, after 3 treatment with erbium glass, we can see the improvement of the acne, and it heals as well. In this case, we did complete facial rejuvenation with a CO2. We can ablate all the skin, and when we do in a cold way, the recovery time is longer. So this is immediately after the treatment. Here we can see how ablate the skin, and that way we remodulate all the process. Here we can see that the treatment after 15 days. The other thing that we do a lot is when we do periorbital rejuvenation, we do the upper BLEF, lower BLEF, and periorbital rejuvenation with CO2 laser. we can use the CO2 as a surgical tool, so we can cut the skin and do the surgery completely with the surgical tool of the CO2. We use the ultra pool CO2 of Lumenis. In this case, we did the upper bleb, lower bleb, and the periorbital rejuvenation. After the surgery, here we have the patient, and we do the CO2 laser in order to improve the quality of the skin. So we manage all the layers of the treatment. So we treat the skin, subcutaneous, and muscular, and the treatment of the backs of the eyes. And this is the result of upper and lower bleb with CO2 periorbital rejuvenation. So we treat obviously the blepharoptosis and the backs of the eye, of the under eyes, and the management of the skin of periorbital. So it's a very good complement in these cases. This case, it was a trauma, and where we put cartilage, and we try to rotate a flap, and when the skin start to die, and we stimulate with CO2 laser, and after 2 treatments of ultrapulse plus the lights, after 3 months, we have the skin more recovery. We use a lot of, fractional radiofrequency with microneedles, and we use as a complement of the surgery as well, mainly in these phototypes from 4 to 6, where you cannot use the CO2 laser. So it's a very powerful tool with different needles. You can penetrate until up to 4 millimeters in order to stimulate the collagen, and as well you can use complements of the pharmacs at that area, or with we treat the scar of acne. You can use the CO2 as well. It's very similar, but this kind of treatment you can use in high phototypes. Here we can see a short video how we use the microneedle. We have 2, the fixer and the Morpheus, and you can use in all the face with different depths in the different area of the face. And finally, the HIFU, that is a complement mainly to strengthen the SMAS. Is deeper than the other technologies, and it creates a lot of high temperatures in the SMAS in order to fractionate. Obviously, we work as a team, and I think that you can complement and improve the surgeries with this kind of technologies. Thank you so much. I don't know if you have any question.
Thank you, Bravo. Thank you for sharing your valuable presentation and research.
Pleasure to share with you all the results of our study, ENT manifestation of COVID-19 in a dedicated COVID hospital and observation study. As we all are aware that COVID-19 pandemic has posed global challenge to public health, and there was not a standard of care in view of inadequate evidence on existing medicines and their limitations. Based on personal experience while working, it was observed that there is a variation in presentation of patients in the form of certain ENT manifestation, ranging from deafness, vertigo, loss of smell, and test to voice change and difficulties in swallowing, apart from sore throat, fever, and dry cough. However, it was not so far prospectively studied with concerted effort. Hence, this present study has been carried out. Besides, as we all are aware that it is imperative to detect the disease at its early stage when it is still curable, especially in COVID patients, as suspicions of disease clinically helps us to identify the affected individuals and help them in isolation and treatment of these patients. However, the behavior of SARS-CoV-2 in some patients has been contrary to observations in the other patient, and this has actually prevented the suspicion of the disease clinically, which has resulted in a delayed diagnosis and isolation of patients infected with virus, and therefore made it difficult to deal with this disease. Therefore, knowing the full spectrum of the possible symptoms associated with the virus is the first and most important step in identifying infected patients. Hence, the study has been carried out with an aim to study all possible ENT manifestations of COVID-19 in a patient's dedicated COVID hospital, with an primary objective to know the prevalence of all possible ENT manifestations and to develop comprehensive checklists pertaining to these manifestations, with secondary objectives being to study the natural history of the disease pertaining to ENT manifestations, to study the prognosis of the disease pertaining to ENT manifestation, to know the deficiencies in the documentation of presenting complaints by comparing the data gathered through concerted effort versus acquired through routine documentation, and to compare the prognosis of the disease between those with ENT manifestations and those without ENT manifestations. So approximately 350 patients were assessed for the eligibility. Patients who did not meet eligibility criteria were excluded as per sample size. Minimum 273 sample size was required. Approximately 30 patients were included in the study. So the study was explained, informed consent was served, written informed consent was obtained, and patients were evaluated prospectively by undertaking detailed history pertaining to ENT manifestations and then were examined clinically from ENT perspective. Retrospectively collected data from the existing documentation used for enlisting all possible symptoms, and follow-up was done on day 1, 3, 7, 14, and 28 days of enrollment. Outcomes were compared between ENT and non-ENT manifestations and their correlation with respect to age, gender, comorbidities, and stage of the illness. And comprehensive checklists were was formulated. The results of our trial are, as we can see here, the overall prevalence of the ENT manifestations on day 1, as we can see here, the most common manifestations which was encountered was loss of taste sensation, and we have further studied the test with respect to test of salt, sweet, sour, and bitter. Further, the second most common symptom was loss of smell, followed by voice change, sore throat, vertigo, swallowing, and auditory deficit. The prevalence of undisturbed taste was 2% in case of bitter and 1% in case of sweet. So it was observed that the patients who had disturbed taste sensation with salt and sour, but they still had preserved taste sensation with respect to bitter and sweet taste. So this was our overall picture of various symptoms. it was also observed that the patients were having overlapping of symptoms. Out of 253 of patients who are having loss of taste, among them 174 patients had loss of smell also. And among 178 patients who are having loss of smell, that is olfactory disturbance, they were, of which 174 were having taste disturbance. And this correlation was huge and statistically significant. Further, it was interesting to note that these symptoms were occult. So upwards of 80% of the symptoms of the patients who are having ENT manifestations are occult symptoms. So that means the patients themselves have not come up with these symptoms, but on detailed inquiry, these symptoms were noted. So based on the results of our study, we have formulated this checklist, color-coded checklist, which we have put in our triage areas to screen for the patients and to get maximum cases detected out of it and to give them early treatment as early as possible. So to summarize, in current study, upwards of 87% patients had ENT manifestation. Out of 308 patients, 269 patients had some or the other ENT manifestations, and only 12.66%, that is only 39%, 39 patients had only non-ENT manifestations to begin with. Greater the COVID severity, greater was the ENT manifestations, except for sore throat and vertigo. Amongst the patients with ENT manifestation of COVID-19, upwards of 97%, that is 263 patients, were having occult symptoms. That is, they had not come with ENT manifestations as chief complaints, but on detailed inquiry and examinations, these manifestations have been detected. Most common ENT manifestation was loss of taste, which was seen in upwards of 82% cases, that is 253 patients of our cohort, followed by loss of smell sensation in 57.79% of patients, that is 178 patients on 308 patients of our cohort. The order of frequency of test disturbance for basic 4 tests were loss of salt, followed by loss of sweet, followed by loss of sour taste and loss of bitter taste. Amongst the patient having sour taste disturbance, the severity of the score decreased, that is normalized on day 3, but subsequently it was worsened thereafter over day 5, and as depicted in the results, the taste of sore remained affected even after symptomatic COVID recovery. This was an interesting finding which we have got in this study. Although our aim was not to see this finding, but this was as an interesting finding which we have got as a result of this study. Furthermore, sensation for bitter taste and sweet taste were undisturbed in 9 patients and in 1 patient respectively, while other tests were affected. The bitter taste and sweet taste remain unaffected in some of the patients, while other tests were affected at the same time. Out of 253 patients in our cohort having taste disturbance, 174 patients, that is 68.7%, has loss of smell. So as to conclude, the overall prevalence of ENT manifestation in COVID-19 in our cohort is very high, upwards of 87%, that is 269 patients out of 308 patients, that is 87.3% patients as per our study. And most of these patients were having occult ENT manifestations, upwards of 97%, wherein the patients themselves have not come with these chief complaints, but on detailed inquiry and examination, these manifestations have been detected. Hence, it is prudent to include These symptoms in history taking and examination screening in fewer clinic and trial site for early detection and appropriate COVID-directed treatment. We have proposed a color-coded checklist which is to be incorporated at trials for COVID screening, and this may aid in expanding the scope of our awareness about various possible symptomatology of COVID-19 in day-to-day clinical practice. It was evident that loss of taste is especially attributed to specific receptors pertaining to four basic tests. It was observed based on the results of the study that bitter tastes remain undisturbed in spite of other tastes being affected. This suggests that the probability that is high with respect to the virus being affecting afferent pathway of taste sensation, and the site could be at taste bud receptors. Mechanism for loss of smell could be due to affection of afferent pathway at olfactory epithelium. Presence of voice change could be associated with possible neurotropism, loss of resonance due to upper respiratory congestion, or could be due to low respiratory reserve in moderate to severe cases. Besides, difficulty in swallowing could be associated with possible neurotropism by the virus. Vertigo experienced by patients could be due to possible affection of vestibular function by the virus, as viral labyrinthitis is well documented in vitro. Based on the results of our study, majority of the patients complaining of hearing loss are having bilateral hearing loss, which could possibly be attributed to affection of respiratory system at respiratory epithelium by virus leading to bilateral eustachian tube blockage, or possibly affection of end arterial system due to vascular coagulopathy associated with pathogenesis of SARS-CoV-2 virus. However, the exact mechanism of affection of these special senses by virus is yet to be known. There is further room for research in this area. These are my references. Thank you.
Thank you, Kulkarni. Thank you for sharing your valuable research work with us.
Thank you, ma'am, for giving me this opportunity. I would like to answer questions if there are any.